IOL implantation in a subluxated cataractous lens can whale the tar out of a surgeon, as it did to me in the right eye of this patient. The capsular excess was difficult to initiate and to perform. Disrupting the weak zonules, and finally the rhexis ran out. The CTR was struggled in but had to be removed. The torn capsular bag had to be stripped out, and ultimately we had to resort to vitrectomy and scleral fixated intraocular lens. However, for the second eye of the patient, meticulous planning, accurate maneuvers, the correct devices at the correct time, and it was smoother sailing. 2 side port incisions are made superiorly and inferiorly. High molecular weight viscoelastic is injected in the anterior chamber over the aphakic area to prevent trypan blue from entering the vitreous cavity. Now, trypan blue was injected over the subluxated lens, and staining was done under cover of an air bubble. To initiate a capsular rhexis, the anterior capsular puncture was attempted with a cystotome. Repeated attempts failed due to the low elasticity of the capsule. A separate nasal entry was made and an MVR blade was used to puncture the anterior capsule. A microrhexis forceps grasped and regrasped the anterior capsule. To provide an opposing force, a ball-tipped IOL manipulator was used in combination with microrhexis forceps. Cautiously and patiently, the rhexis was completed. 2 iris hooks were placed to pull the subluxated lens temporally. Centering and fixing a subluxated lens is like hauling a giant whale. A capsular tension ring was inserted into the capsular bag. This reduced the subluxation to an extent. Gentle hydrodissection was done and the loosened cortical matter was curled out. Temporarily, a triangular scleral flap was created. Since the zonules were specifically weak in the temporal half and there was adequate exposure of the anterior rim of the capsule temporally, the IOL was inserted in the bag from the nasal approach. This port would also serve as the entry port of the threaded Sioni segment at a later stage. Manipulating the single-piece acrylic IOL inside the bag that is half dangling into the vitreous cavity required extreme care and patience. The Sione segment was inserted through the nasal approach and maneuvered into the bag. With the railroad technique, the suture was pulled out temporarily, taking care that the sutures were not entrapped in the incision site or around the device. Adequate pull was exerted to haul the capsular bag, the capsular tension ring, and the IOL complex to give it a central position. And it indeed was a whale of a job. The visco was removed. The remnants of the cortex entrapped in the bag was gently removed. Air was injected in the anterior chamber and the scleral flap was sutured and covered with conjunctiva. In a week's time, the patient achieved a vision of 20/20. All's well that ends well, and it's been a real whale of a time.